I'd like to welcome everybody to today's webinar, which is part of our Improving Ohio's Health series. Today's webinar is Using Technology to Support Your Patients with Chronic Conditions. It doesn't have to be painful. My name is Scott Mash, and I will serve as the presenter today. I'd like to review the topics that we'll be discussing during today's webinar. We're going to focus on the technology, your EHR, and some other tools that you really can use and need to have to support your chronic care management program. We will talk about some of the EHR functions to identify both potential and enrolled patients for CCM, some functions that you can use to document and share the care plan. We'll review enhanced communications that are required by CCM, and really, those enhanced communications, those are patient engagement. I did last month, I did a webinar on patient engagement. If you check the CliniSync YouTube channel, you can find that webinar, and also there's an article from that as well that's posted to the CliniSync webpage. We're going to talk kind of from a high level how you can overcome some of the limitations with respect to your EHR and the chronic care management program, and then I'll provide some of my recommendations. Now, I also think it's important to point out what we are not going to cover, and today we're just not going to get into the minutiae of the regulatory requirements for chronic care management. We've done a series of webinars on chronic care management and transitional care management. I've provided links here to two of those webinars. Also, the CMS has a really good CCM overview. I've provided the link to that as well. That'll get you most of what you need on the underlying regulatory requirements. Even though we're not going to get into the regulatory requirements, I did like this kind of workflow that I found. This is from Pershing, Yoakley and Associates. Now this is a couple years old. I had to tweak some of the pricing. The CCM code has went up just a few pennies, and of course the co-payments went up as well. But really, as you can see from this workflow, you go from left to right. You have your patients, you educate them on the CCM program, you get their consent, the practitioner performs the wellness exam, sees them in the office, they capture some information within the certified EHR, you have a care plan, the care team gets involved with the monthly contacts, and you kind of serve as the hub for all the referrals, all the services that the patient receives. Now, why in the world would you want to undertake a chronic care management program? And I really like this graphic here, this comic, because really when you get down to it, it's about chronic care management is about engaging the patient, about making them an active partner in improving their own health and wellness. And unfortunately, we have a very sick population. 68% of Medicare beneficiaries have at least 2 or more chronic conditions. 36% of those have 4 or more. There's just such a large percentage of people that are unhealthy. They have multiple chronic conditions, whether it's genetics, diet and exercise, lifestyle choices, or just bad luck. This chronic care management program does provide additional funding to really keep those patients focused on improving wellness. And Ohio does have a very, very high occurrence of both diabetes and hypertension. This slide's from a presentation that my good friend and partner, Kathy Costello, did a couple months ago, I believe. This is showing the 2014 chronic conditions. Now, this is from hospital discharge data. 50% or more of discharges across the state have hypertension, active hypertension in the problem list, and you're seeing north of 40% with diabetes, and I believe the occurrence of both was right around 20-25%. So if you have a chronic care program that focuses nothing more on just the occurrence of both diabetes and hypertension, that's still going to be a large portion of your patient base. Now, there are also some financial incentives for considering a chronic care management program in your practice. Nice billing codes, 99490. You're providing 20 minutes of chronic care management per month. This is non-face-to-face time. So there's an opportunity for $42.60 per patient per month that you have enrolled in a chronic care management program. Now, if you project this out, I kind of threw in different patient numbers here because, if you're a small practice, you're not going to be able to handle a lot of patients in chronic care management. Maybe you just want to dip your toe in and really just see, how many patients that you can handle, see the benefit of your patients. Maybe you're down towards the lower end where you're going to have 50 patients in your program. That could result in $25,000 a year for your practice. If you go up to the higher end, 400 patients, if you're a multi-provider practice, large patient base, you've got a good support team, maybe you can support 400 patients in the chronic care management. That could result in $204,000 per year for your practice. Now, this isn't just windfall money. We all know there are going to be resources that are expended to support a chronic care management program. So this just isn't incentive money to your practice. This is money you are going to reinvest back into the improving the wellness of your patient base. Let's dive in and look at some of the EHR functions. And really there are some base functions that are required as part of the chronic care management program. And the first one is you have to have a 2014 or 2015 certified EHR. It's a base requirement. If you're going to drop that 99490 billing code, you have to have certified EHR technology. Now, keep in mind that really what we're talking about here is our discussion's not going to be limited to just EHR functionality, because there are some other HIT tools that you may consider to supplement where your EHR falls short. Now, the functions that you have to have within your EHR or with other supporting HIT technology is, first, you have to be able to identify those patients with multiple chronic conditions that are eligible for the Medicare CCM program or eligible for private payer CCM programs. You have to be able to document that the patient has provided consent and that they're actually enrolled. Now, if you remember from Kathy's recent CCM update, used to be you had to get a signed consent form and get that into the medical record. Well, now you just have to document that verbal consent was provided after education was provided to the patient. So you also need to capture some discrete data elements, and those include demographics, problems or conditions, the medications that the patient's taking, and any medication allergies, and some other EHR functions or discrete elements that you need to capture. You need to be able to perform and record a complete MedRec. You need to document within the record a detailed care plan, and that detailed care plan has to contain discrete elements. It really can't be a scanned document. You have to have the ability to share that care plan with the patient and with other providers. Now, with all the new CMS programs that are coming out, they really want you to share this information electronically, so that way those discrete elements contained in these documents can be consumed by the receiving system, but other means are acceptable. So if, for the patient, you're going to push this to the patient portal, and if the patient wants paper, give it to them in paper. Same with when you're sharing with other providers. You want to send it electronically. If the other provider is unable to receive it electronically, then it's perfectly acceptable to send that by fax. Now, you also need to be able to provide the patient with educational material and the self-management plan. Again, electronic preferred. You need, the care team needs to have timely access to the patient's electronic record and the care plan. Again, this is shifted from 24/7 access to timely access. You need to be able to, within your EHR, document the non-face-to-face care management activities. So those phone calls, that outreach you're doing to the patient every month, you need to be able to document that back into your EHR. You need to manage referrals to the specialty providers, maybe to a community educational program or other support programs. All has to be managed within your EHR or HIT tool. And then you need to provide enhanced opportunities for communication between the patient and all members of the care team. Now, thankfully, meaningful use provide some basic functions. And, you know, for all the problems with the meaningful use program, it's been around forever, but meaningful use serves as a foundation for all these new payment reform models that we're seeing rolled out today, whether it's CCM, TCM, MACRA, MIPS, and now CPC and CPC Plus. These are all built on the framework that meaningful use provided. So for the recording of discrete data elements for demographics, problems, medications, medication allergies, those were all measures within meaningful use. Your EHR, if it's certified, it can do that. The capture and documentation of the MedRec process, that's that MedRec measure. If you perform a full MedRec within your EHR as you are doing today, you are good with the MedRec requirement. Now there is some other meaningful use base functions that you're going to be able to utilize for your chronic care management program, but there are some others that maybe fall a little bit short that you'll need to either supplement or find a workaround for. So, okay, let's talk about step one, identifying the patients that are eligible for chronic care management. And what that means is they have 2 or more chronic conditions. Those chronic conditions are going to last for at least 12 months or until the demise of the patient. There's really 2 ways you can do this within your EHR. If you have an ad hoc reporting tool, you understand how to use your ad hoc reporting tool, or you have a member of your organization or a member of your team that can help you out with that. The ad hoc reporting tool you're going to be able to really manipulate the data and really drill down to find those patients you want to include in your CCM. Probably the quickest way to do it is with patient list functionality. Often overlooked, but the patient list functionality has been included in your EHR since the early days of meaningful use. It was a menu option from day one. Every EHR 2011, 2014, and 2015 certified has patient list functionality. So now there are some downsides with the ad hoc reporting tool. In most EHRs, they can be very difficult to use to very, very easy to use. This is just a quick screenshot I grabbed from the web. The underlying issue with a lot of these ad hoc reporting tools is you have to understand how the data within the database is laid out and how the different tables of data connected together. It can get really complex, really difficult with some of these tools. If you have an IT guru, you have an IT support team, they're going to be able to knock this out real quick. But a member of your care team could struggle with this functionality. So let's focus on the patient list functionality. Now this is a screenshot from the MedEnt EHR. It's got a very simple interface. You dump in a beginning date and an end date. You can leave those blank. You can specify whether the patient has seen a specific doctor, or you can open it up to all. If you leave that blank, it'll be all doctors in the practice. And then you can list your problems. Here we focused on essential hypertension and diabetes. Those are the only 2 problems we listed. You could list a dozen problems if you were looking for patients with any of, let's say, a half a dozen problems. And when you submit that, what you get back, at least in the case of MedEnt, is you get the list of all of the patients between the beginning and end date for that specific doctor, and then you get this great grid. Here you see essential hypertension and diabetes, and you got the yes, no. Well, you could filter that down to be yeses on both, so then maybe that's going to be your start of your chronic care management program is patients with hypertension and diabetes. If it's a yes, yes, those are who you're going to go after to get enrolled. Again, just to show another example of patient list functionality, here we're looking at a screenshot from Athena Health. It's a little fuzzy, a little hard to read, but on the right-hand side of the screen under the filter criteria section, you could, again, put in multiple conditions. You can put in a date range. You can select departments. I'm sure there's functionality that selected a provider, a specific provider. And then, in the case of Athena Health, all of the returned patients you can export to Excel. Okay, either way, with MedEnt or with Athena Health, with Allscripts, with Epic, you have this list. Well, now what? Unfortunately, that's kind of where most EHRs fall short. using the patient list functionality, you can usually generate a list within 5 minutes, but often you have these limitations. Maybe I've seen patient lists that limit the number of conditions. I've seen some EHRs where you can select only one condition. There's really, in most EHRs, there's not a lot of functionality beyond creating the list. So you can create this list, you can export it, you can print it, but then do nothing else. Many have an inability. Once you have that patient list, boy, it'd be really nice if you could say, this patient list is an empaneled list of patients to Dr. X in the practice or care team X in the practice. You can't do that with most. It'd be really nice if you could create a registry and connect to other functions within your EHR from that patient list. But again, most fall short. Now, there is one example. eClinicalWorks has this really nice registry functionality. Now, I'm going to be honest and upfront. I haven't seen this used a lot. I don't even know all the functionality within it, but I really think it's worth discussing here because, as you can see, there's a lot of different tabs across the top, so you have a lot of information that you can put in or a lot of selection criteria. Once you generate this list of patients, you can run reports from that list of patients. You can look at the list of patients, the quality measures, your CQMs for just that list of patients. I'm sure there's some empanelment functionality within there, but eClinicalWorks also has a module specifically for chronic care management. Now, I'm sure there's an additional cost, but between this registry functionality and additional chronic care management functionality, overcoming the what to do with this patient list becomes really, really easy with some EHRs. Other EHRs, we have to come up with a workaround. So now we have this list of patients. We're going to assume that the EHR doesn't have a means of clicking a button and creating a panel or clicking a button saying, hey, these are all my chronic care management patients. But for you and your care team, you want to develop some means to identify within the patient record that the patient is eligible for chronic care management or that they've been enrolled. One thing you could do is place a little CCM identifier in the patient ribbon or the patient information that generally stays across the top of most EHRs when you have that patient up in context. This screenshot is from Allscripts TouchWorks. This is just a quick screenshot of the banner. And this site has CCM yes, meaning this patient is chronic care management eligible and they're enrolled in the program. If they're just eligible and they're not enrolled, instead of saying yes, it says eligible. Most EHRs will allow you to add an item to your ribbon or some visual identifier somewhere that will pop up when you pull up a patient in context on the clinical side of your EHR. I'd recommend doing that for your chronic care management program, some visual identifier. Now we're going to shift and talk about documenting the care plan. Chronic care management does require that the care plan be electronic and contain an assessment of the patient's physical, mental, cognitive, psychosocial, functional, and environmental aspects. You need to record all the recommended preventive care services that you've prescribed for that patient. You have to document the complete MedRec with a review of adherence and potential interactions and oversight of the patient's self-management program for their medications. You need to also have an inventory of all the referral points for this patient, whether it's another physician, whether it's a community resource. You also have to document a detailed plan of care and a detailed self-management plan with goals. Now, I'm not going to go into all the details of the components of the plan of care that need to be in there, and and same with the self-management plan. Those are all available within the actual regulation for chronic care management. But there is a tool almost every EHR has that can make the gathering of this information more simple, and that's documentation templates. What the documentation template really allows you to do is develop this nice template so that the provider it really just asks a series of questions that the provider would either do a mouse click or maybe a mouse click and a few quick keystrokes to go down through and make all the selections. This example is from Athena Health, and I strongly, strongly, strongly recommend you take the time to learn how to create complex documentation templates in your EHR, plan out the required elements for chronic care management or any other program that you're developing a template for, and take the time to go through, lay out a template, test it in your practice, get feedback from the physician, every member of the care team, the coders, and the billers. You really want to make sure that this template's meeting the needs of everyone possible. It's going to be nearly impossible to develop any template that meets 100% of everyone's needs in the practice, but hey, if you can get 80% of the needs and meet 80% of the requirements through the development of a really good, strong template, it's going to be time well invested. Now, template functionality is going to vary widely by vendor. Some vendors, it's very simple. Some you can get these exploding logic. So if you answer yes or no for a question, maybe it'll present another section that normally is not presented. This is an example. I think this example was built, I want to say, in Allscripts Pro. And you can see that it looks very simple. You can go down through and click, 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 and make a half a dozen choices, and it will yield a care plan that is easy to read, broken out in sections. It can be easily printed and handed to the patient, pushed to the portal. It's pretty, it's laid out very well. It's easy to understand. It's easy to communicate. Again, the time you invest in the setup is going to yield extremely high returns later in the game. It's going to make the visits more efficient. It's going to make all the communication with the patient more efficient, the education more efficient. It's when you share this with other providers of care, when doing a referral, it's broken up very well. It contains all the needed elements. So get creative, engage your EHR vendor, take the time to read your documentation, sit through training, learn how to build these documentation templates front and back. And again, the time you spend building the templates, refining the templates, will equal more face-to-face time with the patient. It'll allow your care team to look away from the EHR, lay hands on the patient, and really care for the patient during not only the office visit, but also those, you can use these templates for your non-face-to-face care management calls and engagement of the patient between visits. CCM requires that the care plan be available. You got to have timely access. It used to be 24/7 access. To kind of reduce that back to timely. And really what they're saying here is as you expand the availability of your services to the patient, you're expanding into the evening hours. Whoever's taking that call needs to have remote access to the EHR so they can access the patient's care plan, they can access their full medical record. Now, there's some other ways that you can meet the timely access outside of your EHR that we're going to talk about here shortly. CCM also requires that you share the care plan with other providers of care and the patient. They really want this care plan to be shared electronically, with the interoperability functions of all HIT are under a great deal of scrutiny by CMS. They want to make sure that this data can be shared across all platforms and consumed to make us all more efficient so we're not re-entering data and whatnot. So every single EHR that is 2014 or 2015 certified does allow for the care plan to be shared electronically using the direct protocol. Some of them use some other means, but primarily the direct protocol's out there. Now, direct is widely available, but in my opinion, very underutilized. A lot of times folks are sending these care plans electronically via direct so they can click that meaningful use requirement, but then they walk to their fax machine. I think over time we're going to see a greater adoption of the direct protocol, and I guess more trust. Really, it's not adoption, but it's trusting that the protocol is there and building workflows around the sending and receipt of documents electronically. Now again, using direct or some other electronic means is preferred over faxing so that all the information in the care plan can be consumed by the receiver's EHR. With that fax, you've got this static document that's attached. There's no functionality, and in many cases, the receiving provider may have to re-enter that information. Now, sending things with direct also does help you meet your meaningful use requirements. So, hey, it's another reason to utilize direct or some other electronic means. But again, is another way that you can meet both the availability requirement and the sharing requirement for chronic care management. And this is by utilizing standard HIE functionality. In the CliniSync HIE, we call this the community health record. So if the provider, the practice is contributing data to the HIE, they can build that care plan, share it to the HIE, it'll be posted to the community health record. That way it's accessible to pretty much any provider, hospital, anyone in the state who's participating as a member of CliniSync. They can go in there, they can pull up, John Doe, look at his care plan. That will meet the sharing requirement for chronic care management. It also will help you meet the availability requirement because the CHR is a web-based portal. So if you're a member of a care team, you get a call late at night from a patient who's enrolled in CCM. Maybe you don't have immediate access to your EHR, but you can log into the CHR. There's the care plan that you submitted. There's all the patient information that you've submitted. So now you can, you can answer those questions for that patient late at night. Maybe, just maybe, prevent an unneeded visit to the ED. I did drop in a couple quick screenshots from the community health record for those that haven't seen it yet. This right here, this is one of our test patients. You can go in, you do a quick query, you can get a patient summary, and you can see here that you can see results, care summaries, allergies, problems, medications. You can, down the left-hand side, you can go to encounters, results, meds, docs. There's more and more and more information in the community health record every day. All of the hospitals that have been members of the HIE that are sending out results and other information, they've been contributing to the community health record since those respective hospitals went live. We're now bringing on a lot of ambulatory sites have expressed interest, and we have several practices that are contributing the ambulatory data, and we're seeing that ramp up. Our goal is very, very soon we're going to have post-acute posting information to the community health record. And this is just a quick screenshot of what a document inside of the community health record looks like. Pretty much if you build your template for your care plan, for the self-management plan, you build your template, you push it over, it's going to present within the CHR pretty much how it looks within your EHR. Now, the standard CCDA document does tack on some information at the beginning and the end, but within that overall document, you will find your care management plan as you've defined it within your EHR. Now, most of the the communication for the care management activities, those interactions between face-to-face visits, are going to take place by phone. But don't overlook your patient portal as a supplement to enhance those care management activities. Everyone has a patient portal. Some health systems have 2 or 3 based on their number of EHRs. But we go back to meaningful use. We know that most practices have these portals. The portal is a great tool for sharing that information electronically with your patient, sharing that self-management plan, the overall care plan, They've got their meds, their allergies, they've got all their problems listed. They can see their results. You can send a secure message. Maybe you've tried to call the patient a couple times and they're not responding, they're not picking up their phone. Go into the portal, send them a secure message. It's also secure messaging is a great tool for the patient. We all carry around the cell phone nowadays. Most of these patient portals have an interface that'll work on a smartphone. I know I personally, when I'm setting somewhere, I think, oh geez, I need to get a hold of my physician and request a refill on my medications, or I have a question about maybe I'm having a reaction to a medication. I picked up my cell phone real quick and sent a secure message to the portal. Great tool, great tool. Just do not overlook it. It's also a great tool for reminding the patient of an upcoming appointment. Perhaps you could set up a dummy appointment type for those care management calls and send those reminders through the portal as well. But just do not overlook your patient portal, because really enhanced communication is patient engagement. Again, patient engagement, a central theme in all of these new payment reform models, including CCM and including CPC Plus and including MACRA. Now, every EHR is going to have different functionality and different limitations with what you can really do in support of your chronic care management program. There's going to be cases where you have to develop a manual workaround. You have to develop a complex workflow, or just something to offset where your EHR falls short. Some common problems that I'm seeing written about with chronic care management is some EHRs just don't do a good job of handling the documentation of those non-face-to-face encounters. And where we see the biggest problem with that is, the CCM requires that 20 minutes a month of non-face-to-face time. How do you document that? Most EHRs, when you pull up a note, they don't at least visibly timestamp or show you a countdown of how long you've been in a note. So maybe, when you're starting a care management note, when the patient picks up the phone, you look at your watch and you type at the top of the note that, the call started at 12:01. And then maybe the call went to 12:30, so the last thing you enter in the note is, call ended at 12:30. So at least you have a means of recording that start and end time. The management of patient referrals sometimes can be very difficult in an EHR. The way I see most referrals done is you order a referral. So you're inputting an order. It shows the order going out. A lot of EHRs just don't do a good job with closing that referral loop, or at least it's very difficult. Or what if you're sending a patient to 5 different referral points? So maybe they have diabetes, or they're pre-diabetic, and you're going to send them to a DPP program, a diabetes prevention program, or you're going to send them to an endocrinologist, and you're going to send them to 3 or 4 different points. It can be really hard to get an overview of all of those referrals. And I'll tell you right now, where most EHRs fall just flat is the ability to refer to a social service agency or a community education program, or maybe you have a program at your local YMCA. And most EHRs just don't have the ability to do that. So again, shameless plug for CliniSync, but think about the referral tool. Or it doesn't necessarily have to be the CliniSync HIE, but there are some other referral tools that really expand on the limited functionality in an EHR. And I just want to show the CliniSync EHR, or CliniSync HIE referral functionality. The great thing about the referrals inside of our HIE is we can set up any endpoint that really wants to join, that provides some type of patient-based service that wants to join that medical neighborhood. So let's say you've got a patient that needs Meals on Wheels. They need, maybe there's a great program at a faith-based organization. We can set up those endpoints. We can engage those endpoints. But the great thing is when you pull up the referrals for a patient, this is showing one particular patient. You can see here where the patient went. You can see the status of these referrals if the receiving site goes in and says, hey, we saw a patient, we closed it out. But you get a lot more information here in one section than you probably do in most EHRs. So again, think about the limitations of your EHR and the available tools out there that can supplement what you have or what you need. Again, this is just another screenshot that, of the creation of a new patient referral, some of the options that are available. All right, we see a lot of organizations popping up that provide outsourcing services to support chronic care management. And I can tell you that I've talked to several practices that have used outsourcing, and there are varying degrees of success. What I would recommend is sit down, look at the budget side. Let's say you're going to project that you're going to put, initially you're going to do 50 patients in your chronic care management program. How much intake are you going to have? What are the resources you're going to expend to provide those 20-minute care management activities each month? What are the resources you're going to expend by an extended face-to-face visit to evaluate the patient for chronic care management or to develop the self-management plan? Just kind of see if you can offset the increased resources with available resources within your practice, or by maybe making a part-time staff full-time. You got to really sit down and first look budgetarily. Now, the services that these CCM outsourcing groups provide is they'll help you pretty much with anything, from assisting with digging into your EHR and identifying which patients are eligible, or maybe which patients you want to focus on that are eligible. A lot of these groups, they do the monthly care management activities with the patients that you have enrolled. Sometimes they'll provide another portal for the patient to log into so they can view their care management or the self-management plan, or update their self-management plan. Some of these CCM groups will actually go back into your EHR and document the call activity. Sometimes they will have a separate EHR or separate clinical system where they'll do the documentation and interface things back, or fax. There's just all different levels that these programs provide. Now there is a downside. A lot of the problems that I hear is that the best way to engage your patients and to really keep them focused on themselves is to develop a relationship. You know, in the small practice especially, you know the names of your patients. You know them when you're out on the street. Your whole care team knows that patient. They know the history. When the patient walks in, if they got a call from Nurse Betty, when they walk into the office, they see Nurse Betty, and Nurse Betty can say, "Hey, how are you doing? Just since we last spoke." You kind of lose that with these outsourcing groups. They don't really know your patient. Now, when they make the calls, they'll say, "Hi, this is Nurse so-and-so from Dr. Bob's practice," or whatever your practice name is. They generally present themselves as a member of the practice. So the patient may perceive that that person is sitting in your office. But when they come in, if Nurse Betty was the one that called them and she works for the outsourcing group, they don't see Nurse Betty. So you lose that personal touch, and you're giving up some level of control. How well did they this group run through the care plan? Did they really focus on the points of the self-management plan that you would have focused on? How much are they taking off the top? Generally these groups take a percentage of that monthly $42 a month. Are they taking half? Are they taking 75%? There's a lot to weigh back and forth here. And I'm not going to say don't outsource, because I think outsourcing for some practices is a perfect fit. For other practices, I think it's a terrible fit. You just, evaluate these groups individually, look at your needs, make a decision of what you're going to do in-house or out-of-house. Now I'm going to provide you with my recommendations. Again, this is just my personal recommendations for an approach to chronic care management. Doesn't represent CliniSync, doesn't really represent those that are funding this webinar. Just if I were sitting in your seat, this is what I would do. I would not be bleeding edge. Do not break new ground with chronic care management. Now, there may be some progressive group out there that has a great idea where they want to break new ground. That's awesome. Go for it. But get in touch with your friends at other practices that have already sat down and have a successful chronic care management. Call them, drive over, say, hey, what did you do? Can you share your workflows? What did you do that didn't work? Where were your failures? Where were your successes? Where were your early wins? Just rely on the information you can garner from others. I'd also recommend that you start with a limited number of conditions that's going to make the greatest impact. Again, hypertension and diabetes, to me, that's a no-brainer. There's such a high prevalence of that in Ohio. Start there. Start your CCM program with nothing more than hypertension and diabetes. Identify 50 Medicare patients within your practice that are at a high risk, or they're just not managing those conditions very well. Focus on them. Get them enrolled. Work out the kinks of your chronic care management program before expanding it. After you've kind of talked to the other practices, you know what population you're going to focus on, sit down with your care team, sit down with your billers, your coders, sit down with everybody, brainstorm make sure that everybody has a base understanding of the requirements of chronic care management. You guys develop a goal and then develop a very detailed project plan, that you have to modify your EHR for X, Y, and Z. You've got to develop this template. You've got to create a manual workflow here and lay out the job segmentation, how you're going to break up these tasks. Just get into the minutia and lay it all out on paper. Set some great milestones, some date-driven milestones, so that way you guys can make sure that you're progressing through and that you're not wasting resources. Because let's be honest, it's not a ton of money that you're going to get from this. But again, it's about improving the care of your patient. I would really recommend you engage your EHR vendor very early. You're paying maintenance, you're paying support, you invested in the EHR. Get your EHR vendor on the phone. If you need the document template training, see what you got to do to get that training. Get the documentation so you know how to build these templates. Ask them about how other clients are handling chronic care management. I'll tell you, I know most of the vendors that I've dealt with in the past, when there was a new program, I would call them up and say, hey, who's the site that's leading the way in X? I mean, that's what I did in the early days of meaningful use. Is I called my vendor and said, who's winning the game with meaningful use? They gave me a name, they gave me a contact, and I called that person, and I spent a lot of time on the phone with them. I'm sure if you're an Allscripts client, you're a Greenway client, you call them up and you say, who is the site that you would point to that's doing the best job at chronic care management? They're going to give you that information. There are some questions that I would recommend that you ask your vendor at the very beginning of considering a chronic care management program. First, ask them, does your EHR support documentation of care management outside of a face-to-face visit? If so, how? If not, what can we do to modify the system to make it work? Is there an add-on I need to purchase? What's the cost? Vendors are very well known for the old nickel-dime approach. You buy this piece of functionality. Oh, wait a minute, you wanted to also report on it, so you got to buy this over here. Just lay it all out to them, get a quote if there is going to be an additional cost. Ask them, does your EHR have the capability to document the time expended on a patient encounter and track that on a monthly basis? This is around the care management activities. Is there a way within the EHR to build a trigger so when you start a note that you know that you spent that 20 minutes with the patient, and that would also trigger the EHR to drop that billing code if you've exceeded the 20 minutes between each month? It'd be really nice if there's a way to automate that. Does your EHR have the capability for developing a complex plan of care and a complex self-management plan that meets the full requirements of chronic care management? Many times you'll find that your EHR vendor has a template that they'll share with you. Maybe it's a template contributed by another organization that's doing chronic care management. Some of the EHRs, you can copy that logic, export it and import it into another EHR, and it'll work just fine. Find out if your EHR has a means of impaneling patients enrolled in CCM to a care team within the practice. What that really means is create a patient list and assign that list to a care team. So that way they can go into the EHR and quickly identify the patients that they need to get in touch with that month, or some other functionality around that. Now, I also did want to provide links to our previous webinars in this series. Currently, this is the last Improving Ohio's Health webinar that we have scheduled. We're hoping to do some more here very soon, but I wanted to provide you links to each of those. This webinar, these slides will be sent to all of the attendees of today. Actually, they're posted as a handout within the application. You should be able to click and find the handouts feature. But quick and dirty way to find these, go to YouTube, search for CliniSync. You'll find the CliniSync YouTube channel. We have a playlist that contains all of the Improving Ohio's Health series. And we've done quite a few of these. I believe today is the 8th webinar that we've done. Also want to let you know that I'm working on an article that kind of provides a little more information than in some areas. It's going to be on the exact same topic, just in article form. We're kind of working out the kinks with that article right now, and that should be posted to the CliniSync website soon, and Dottie will include it in one of our upcoming newsletters. We are still actively collecting data around hypertension and diabetes. What we really want is the CPHIMS for NQF 0059 and NQF 0018. If you'd be willing to share your clinical quality measures for all of the providers in your practice, we would really, really appreciate it. Contact Kathy Rich at crich at OHIP Online if you would like to contribute data. Be sure to check out the CliniSync website. Sign up for Dottie's newsletter. She does a great job. We try to pack as much information as we can about upcoming payment reform programs, these webinars. All of our webinars we put in the newsletter. We actually share some webinars information for some of our partner organizations. We have a lot of updates about HIE functionality. Folks that have joined the HIE, the newsletter is just an absolute great resource. I'm going to open it up to questions. The way we do questions is you should be able to find the questions feature within GoToWebinar. Enter your question. If you can't find the questions feature, go ahead and enter it into the chat box. I have provided our contact information for both the team we're working with at Ohio Department of Health, Michelle Show and Richmond. And of course, most of you probably already have Kathy and my contact info. But by all means, if you have any questions related to the content of this webinar, any of our past webinars, chronic care management, transitional care management, any of the payment reform models, do not hesitate to email us. We're here to help. So I am going to pull up the questions. We do have quite a few. Just a second to kind of reposition things here to make it a little more readable. All right, question 1. I know not all EHRs are equal, but how do I know if mine can even help me manage my CCM patients? Well, I think every EHR will provide you the base functionality you need to support your chronic care management. You're going to have to put some workarounds in place for certain functions. Pick up the phone, call your EHR vendor, tell them what you're doing. Tell them you're going to institute a chronic care management program within your practice. What recommendations do they have? Do they have a document already prepared for it? Some of these EHRs do a really good job with creating step-by-step manuals for these different programs. So, log on to that support portal that most have and search for chronic care management, search for CCM, search for TCM, and see what you can find. Google. A lot of groups will kind of go around normal support and ask the question on some forum, and Google's a great resource. Google is an absolute great resource. Will MACRA and MIPS affect CCM and TCM, and if so, how? Well, yes, it will. Depending on if you're going to go down an advanced payment model track, Some of those APMs will have additional requirements over and above CCM. They will also, a good example is CPC Plus. If you are enrolled in CPC Plus, you're selected for the CPC Plus program, we'll say on the Medicare side, your Medicare patients would not be eligible for a portion of the CCM payment because it's rolled up in the CPC Plus program and those funds are giving you. So yes, MACRA, MIPS, APMs will have an effect on CCM. We just got to wait to see what the final rule looks like. How do we determine what timely access means in the real world? You know, I would say timely access means if you get a call at midnight and you can't access the record, that, you know, you make it a point to get in the office early, pull up that patient and get back in contact with that patient. In my mind, you know, that would meet timely access. They don't really give you, within the regulation itself, they don't define what timely means, but I would say real world is early the next morning, early the following morning. Just a quick comment from someone thanking Kathy and myself. They found the series informative and hope that it will continue, and we do as well. This is one series that we see a lot of value in. We're really hoping that we can continue this series and maybe add in a few more. All right, next question. We have started CCM with our patients. We generate our list for all patients coming in tomorrow who have at least 2 chronic care conditions. We have a form that their medical assistants present to the patient. They explain it, and then they get the patient's signature. And this group is actually using a CCM outsourcing company, which they fax that form to. And that organization has a medical assistant who makes the calls and then comments back into their EHR for sign-off. They also add the flag that identifies the patient's already under chronic care management. You guys are ahead of the program. That's exactly, you know, if you're going to use an outsourcing agency, it sounds like you have a very well-defined process. Keep in mind that while I would continue the practice of getting the physical signature, though it's technically no longer required, as long as you get you go through the education of what the chronic care management program entails, and you get verbal. You get the verbal consent and you note the verbal consent somewhere in the record, that's fine. But the signature, I would not stop that practice. That's a good firm practice and continue even though it's technically not required. That's the last question I got. I'm checking the chat real quick. Well, guys, thanks for joining us for today. We've answered all the questions. If you had a question and didn't get around to entering it, send me an email. We'll make it a priority to answer your question. For everyone who attended today's webinar, you will receive a copy of the slides if you've not already downloaded them from within the GoToWebinar app. But we'll send you a copy of the slides as well. This webinar was recorded. We'll get this posted over to the CliniSync YouTube channel here in a few days. And thank you for spending time with us. Really appreciate it and look forward to seeing you again in the future.